welcome to the EMS Interoperability Task Force call for January 2024. I'm Josh Legler, a consultant for the NEMSIS Technical Assistance Center. We're going to be revisiting the topic of patient identification and record matching today. It was a topic we addressed in the November 2023 call, but needed some more clarity around the standards and profiles that are used to really do the patient identification and matching piece across a health information network. So we'll be diving into it again today. Here's the big picture overview. We've gone through a bunch of topics on the task force. And as we start into this new year, we anticipate that this task force will continue to meet through the winter and spring, and then we'll probably be able to wrap up by summer. We'll see what else comes along that we need to identify and how quickly we make it through things. We have a couple topics left to address after today's topic. One is the APIs to implement to exchange documents across networks. I think we've touched on that a little bit, so we'll see how much more we need to do there. And then the data elements to be shared and parsed. So that's going to get a little more of a clinical perspective, saying, well, what is it that's really important to an EMS provider to have on a patient's medical history, and what does the hospital staff need, not only the clinical staff, but maybe others, and what outcome data does EMS need to get back from the hospital? So the idea being that once we've identified all the standards and profiles that we're going to use and we're exchanging documents, then what pieces do we pick out of those documents to present to a provider that's going to help them give care to a patient or evaluate the care they gave. So that's what we're looking ahead to with the rest of the task force. Let's see. Before we go any further, I just want to check and see if we have any new participants on the call today. But as I look through the list, I think everyone looks familiar to me. Anyone who's joining this call for the first time? Okay. All right. Before we jump into today's topic, just wanted to give you a quick bit on the EMS Data Summit that was held last month in Washington, D.C. in conjunction with the annual meeting of the Office of the National Coordinator for Health IT. A recording of that Data Summit is available on the NEMSIS YouTube channel, and Lisa has put a link to it in the chat. So we've got the recording out so far, but a couple additional products will be coming from that summit. Kind of a brief what we heard overview, as well as a detailed meeting summary and notes from the meeting. So we appreciate the participation of everyone who joined either in person or remotely for that call. I think we had 200 to 250 people participating. So thanks everyone for the participation there. Okay, so let's dive into today's topic. So looking at the standards and profiles to implement in the patient identification stage of the interoperability workflow. The questions that I want to make sure we get through today are what standards and profiles are used for that phase of the workflow? And specifically looking at the EMS software products, what actor or role do they play? What pieces do they need to implement, and from what perspective? We also hope to have Catherine Lusk with us on the call for some additional information that could help us with improving patient matching by better standardization of patient names and other demographics. I don't see Catherine on the call yet, so hopefully she'll be able to make it. So we're going to start out with John Moehrke. And the bulk of the time today will be with him to help us understand these IHE profiles. So just as that big picture overview, we're looking at this step, this phase in the interoperability workflow where we do patient discovery. So last in the November call, one of the methods I think we heard for doing patient discovery, if you could call it that, is that after EMS delivers the patient to the hospital, they get a face sheet from the hospital and it has an encounter number on it. And then later, EMS can use that encounter number to query for the hospital's outcome data. So that's one method that is being used today. Of course, the downside of that method is that it only works after EMS has treated the patient, not before. So can we implement other methods that are more automated and that can be more upfront at the beginning of the EMS call, where they can identify the patient they're treating quickly and get some quick medical history on that patient. And then everything downstream can tie to that patient identifier once they've gotten it up front. So in order to do that, we've got to be able to look up that patient up at the beginning. And in this phase of the workflow, there's several of those IHE profiles listed there: the XCPD, PDQ, PIX, PMIR. So those are the ones that we're going to have John help us dive into today to understand how each profile applies to the EMS use case and what role the EMS software vendor needs to play in those profiles. So with that, John, I'll turn off my share and I'll pass it over to you to pick it up from there.
Excellent. You're a better straight man than I was expecting, and I feel bad that I didn't think. Oh, sorry about that. Stop that. Huh. I didn't realize I didn't remove Spencer's. I copied Spencer's.
Oh.
So, you know, standards people love to copy. Okay, let's try this again. Anyway, I was just saying, you went ahead and showed the slide that I didn't even think that I should have shown in the from the EMS flow. I guess I should have. So yeah, what I'm going to do is go a little deeper into some of those, and not all of them, and I can speak to all of them a little bit more if necessary as we go. So what I'm going to focus on is, oh yeah, there we go. So first, I've been encouraging, everybody to just, think about, well, hey, if EMS were just a participant on the nationwide health information network, you wouldn't have to have many point-to-point connections. You just have one connection to the nationwide network. And TEFCA QHIN is the latest buzzwords in that space, but essentially it's still this nationwide health information step. And from there, the first thing everybody has to worry about is security and privacy. But the second thing is looking up patients. And third, then you go get the data or interact with the data. So really this second step is very important, and that EMS overall flow, kind of shows that as well. So I'm starting with the use case that, hey, EMS needs to get to the patient medical history, the third step, and therefore they have to find out what the identity is in the nationwide health information for that patient that they have. Now, I think this works fine with either a transport or an EMT situation. I'm not an expert in the EMS flows. I've learned enough that I am more dangerous than I was when I knew nothing. But essentially, the idea is you've got some portion of demographics. Maybe their name, maybe not. Maybe a driver's license ID, maybe not. So whatever kinds of information you have, how can you even possibly do this step two? And that's kind of the use case that we're looking at. Now, most of the nationwide health information exchange is dealing with workflows where they probably have a little bit better, but quite literally, emergency departments are today using this. So emergency departments don't necessarily have a much better situation than you do. They apparently haven't turned off the timing either. So today, in the nationwide exchange, IHE's XCPD is what's used. They're working towards a future where FHIR is going to be used. There's certainly some leading work with FHIR, and I'll get to that. but I really want to start with the fact that the nation exchange is foundationally XCPD. XCPD, unfortunately, in some cases, is based on HL7 version 3. And it's one of the only places where HL7 version 3 messaging is still used widely. And it's primarily because of this particular use case. AHI did profile it to reduce optionality like we normally do to make sure that the request and the response are more tightly defined to get better interoperability. It's been profiled to support multi-hop federation because the Nationwide Health Information Exchange is not just one network, it's really a network of networks. So how do you send a request into this network such that it can propagate to all places that could potentially know about this patient and get you back a result? And how does that result come back to you? So you get back the matches, which might be more than one. So sometimes you have to look at the matches and compare it to further information that you have. But it also tells you what specific endpoints across this network have information about this patient. So within this one request, you get a patient identity lookup, and you now know that these 5 locations have information about the patient. So hence your step 3, you only have to go after those 5 locations to find information. It is complicated because it uses this SOAP stack and HL7 v3. Some people say that the SAML security tokens and the mutually authenticated TLS are problematic. So, I'm upfront that there's certainly plenty of people who will say this is too complex, but it is what is out there today. And there's solutions available. All the EHRs already do all of this. There are infrastructure solutions, readily available. There are open source implementations readily available. So theoretically, you don't have to deal with this complexity because you just grab something and use it. The XCPD, this is an example of one XCPD request to look up a patient. And no, I don't expect you to see it. I've excerpt on the next page the specific parts that are important. Inside of that mess is a parameter list, and there's a set of parameters. These are HL7v3 defined parameters. So the living subject administrative gender. So yeah, they're male. You know that. You see that. You know their birth date, so you put their birth date in. In this case, they know the first name and the last name, so they put that in. And in this case, in this example, they have some other identifiers, and these are just kind of examples. But the idea that if you have an identifier, you can put it in here, and in general, if you have identifiers and the server sides know of those identifiers, it's an exact match, right? So if you have a driver's license number and the hospital has a driver's license number, boom, there's no question. We're not dealing with Jimmy Jones, and is that Jim Jones or what? So, but the idea is with XCPD is you just send in the information that you have, and it's up to the other participants, the responding participants, to use their algorithms for how do they match if given this pieces of information, and they may actually have policies that go through all kinds of Jimmy renditions, or they may have a policy that says, well, if they said it's Jimmy and I don't have Jimmy, then I don't have Jimmy. So again, the matching is on the server side. Some server sides might have very liberal matching, and therefore they might come up with 2 or 3 possibilities. So the response, and I'm not showing a response, but the response that you get back is a list of potentials and where those potentials are. So ultimately, if you get back something other than exactly one, you kind of, do have to look at it. But theoretically, when you get back a singular match at a particular location, it's probably a strong match. Go ahead and grab the data and then look at what the data says this patient was. So this can be quite automated. On the other hand, we're dealing with patient safety, so you do have to, at some point, do some checks and balances. So XCPD is complex, and I'm going to pose here that really the idea of dealing with XCPD is perfectly fine. There's plenty of users and servers that use XCPD. It's not hard, but you know what? The whole idea of having an intermediary is that you could potentially use a simpler technology at your end. So this is the picture from ONC of the QHINs. Within the QHIN networks, as I said, XCPD is used, but they don't say that out there on those leafs, over here, that you can't use something lighter weight. And invariably, there's plenty of lighter weight things that are used within specific QHINs. And you might use completely fire over here. So the EMS providers might be down here using fire, and that gets bridged up to this XCPD. So that's certainly possible. You don't have to always take the pain all the way down to the end. But what then would you use? Well, IG has PDQM. It's a profile rather similar to XCPD, except that it's purely fire. It again allows you to look up based on demographics. It uses a simple fire query. So this is the fire query. You can see here that the family is MOHR, the given of Alice. Want active. You don't want deleted patients. In this case, gender female. And in this case, the results would be based on that search criteria. And this is what we have in PDQM today. It is rather similar, except that it's intended to use the fire in its most native form, and therefore fire query parameters, and therefore the fire query parameters are kind of strict in how you're supposed to deal with them, even though there certainly is some wiggle room. So a fire server is allowed to use some fuzziness on given of Alice. But generally speaking, the idea is, you're supposed to be, providing back results that have a given of Alice. So an intermediary could translate this simplistic API request into that XCPD request, and the results that come back could potentially be retranslated back into the fire response and returned back the fire response. And this is what we have in there today, but there's something better that we currently have out for public comment. Comment actually closes tomorrow, so if you take a look at this and you want to comment, comments are always open completely to the public. So we now have the use of this fire operation. Now, a fire operation gives the clients and the servers a little bit more, some might say power, some might say leeway, but essentially within the dollar match operation, we have something more similar functionality-wise to the XCPD in that you put in the information that you have. So, hey, this is the identifier that I have, let's just say a driver's license. This is the name that I have. This is the gender. In this case, it's set to an other, birth date, some address, blah, blah, blah. And essentially the client just sends in what it has. And it's up to the server to use its policies and its algorithms to find the best match and return the best match. In this way, because it's an operation, we also have a little bit more leeway, like we did with XCPD, to do fuzzy matching. With this, we have, like with XCPD, the ability to take a little bit longer to respond and respond with a little bit more fidelity to the results. So really, we're thinking this is really the equivalent, the fire simplified front end equivalent of XCPD. Still, the QHINs, as you saw, up here, the QHINs would still be using XCPD, but you wouldn't care because you're using fire dollar match. So you have two choices within PDQM. This is really just listing them. I've kind of already covered them, but the idea, the important part is that with dollar match, the servers have a little bit more leeway to do matching authority, doing fuzzy matching, doing knowledge-based depth. The dollar match is potentially a little bit more friendly to automated workflows, like you might have, right? Where, hey, this is what I have. If you give me one result, I'm just going to go after it. So that perspective, it requires less thinking on the client side. So really, I would think that if there is an intermediary in the EMS community providing the dollar match on the front end and using XCPD on the back end makes a lot of sense. So the patient demographics query for mobile is out for public comment. Like I said, tomorrow is our deadline. That's the link. The QR code is there. If you really want to use QR instead of typing that in, highly recommended. And that's it. That's all I had.
John, thanks for that information. I think that clarifies a lot. One thing I wanted to just remind people about, in IHE profiles, you'll see the M show up in several profiles, which stands for mobile, which if I understand correctly, that's really just kind of been IHE's shorthand for this profile uses fire. Is that right, John?
Yes. Yeah. And in hindsight, you always, question the decisions you made, but we use it only where we're taking a previously analyzed use case that chose something that made sense, 5-10 years ago, but we're evaluating it in the current standards environment where support for mobile equipment is important, and therefore the selection of fire will dominate that choice. So PDQ has an HL7 V2 lineage. So our first version of PDQ, we used HL7 V2 because that was what was used within the hospitals, which was the use case at the time. PDQ V3 came out when people wanted to use HL7 version 3. Version 3 has died, so you don't really see PDQ V3 much anymore, but it still exists, but not really. And so, yeah, a couple of years ago, when fire was coming forward, we said, well, let's take the exact same use cases. Therefore, we still have PDQ, but we have this additional criteria that we needed to be able to support clients, to support at least clients that have a need to use lighter weight technology. Because, of course, V2 and V3 are pretty heavyweight technology. So it is recognizing that the reevaluation is for lighter weight technology like mobile devices, but that doesn't mean it can't be used beyond lighter weight technology. So it absolutely can be used between two big irons, within the cloud. But if I had a mobile app, I would certainly prefer PDQM over PDQ or PDQ v3.
Okay, yeah, thank you.
Thing as long, I mean, you're having me go through the other choices. You'll also see that similar in PICS. And what's the difference between PICS and PDQ? PDQ is intended to be a more open query. PICS is very, very specific to, I have an identifier, might be a driver's license, but it might be a medical record number, but I have an identifier and I just simply want the list of identifiers that are mapped to this. So when you have a network of different hospitals, each hospital will have their own MRN, and some patient identity cross-reference system will cross-reference all of those and say, okay, for patient 1, 2, 3, 4 in your domain, it's also known as 5, 6, 7 over here and 7, 8, 9 over there, and blah blah blah. So it's a cross-reference system. So that's what patient identity cross-reference PICS is all about. And again, yes, we have PICS, which is HL7 v2. We have PICS v3, which is HL7 v3, and we have PICS M, which is using FHIR.
So I see a couple potential scenarios for PICS, though kind of limited. One would be in that use case I described where EMS gets the identifiers from the hospital in kind of a paper handoff at the ER. The EMS provider's software could potentially do a PICS query using that ID that the hospital had provided, and then get all the other IDs for that patient, and then go query the network for medical history. But like we said, that's after the EMS call has already ended, so it doesn't really matter. So it would only be in a case where maybe EMS already had the identifiers for that patient, a repeat patient that they go to on a regular basis. They already have the identifiers for the patient. They want to find any new medical history for that patient, so they go ahead and do PICS to find any new identifiers that have been created for that patient, and then just query for medical documents.
Yeah, I mean, that, strictly speaking, could be a use case for PICS, but realistically, I'll say don't worry about PICS, because you can always put identifiers into your PDQ or your XCPD, and I encourage that. So if you have a medical record number, you just put that medical record number in as an identifier. And if you don't populate anything else, this, functionally will only be doing an identifier lookup, but nonetheless, that way you're only using one API. So, PICS, the use case, and here's, I'll go with this one. The real reason why some want to use PICS is because their application or their organization, the client requesting organization, is not authorized to see the demographics. Therefore, they must only use identifiers. PICS will not show you the demographics. PICS will only give you a list of identifiers. So it's more a what gets returned to you than what you have to query. And that's why I said it's kind of an unusual circumstance. But again, you could use it, but it just means that your infrastructure has to support both PDQ searches and PICS searches. And why just make sure everybody does PDQ well.
Yeah, great. So it sounds like in the EMS use case, we can really focus down to PDQ and maybe XCPD. And I wanted to ask about that. So since the network to network communication today is using XCPD, could we assume then that if an EMS software vendor connected to any existing network today, that the XCPD option would pretty much always be available?
Yes.
Okay.
Yeah. As it is today, this is mandated to be using XCPD. They do want to move away from that, but there isn't yet a maturity of how do I deploy a fire at all in this kind of federation, and much less how do I deploy a patient identity, which has some specific privacy issues to deal with in this kind of an environment. So we're working towards that. AHI and HL7 and ONC and Argonaut, we're all kind of trying to get to a fire-based infrastructure. But today, XCPD works, and there's really nothing wrong with it. So yeah, XCPD is what is the QHIN lingua franca.
Okay, yeah. So since the networks have to do XCPD to talk to each other, then it's, I'll just say trivial for them to go ahead and expose XCPD to their participants. And then depending on which network an EMS vendor signs up with, they may have access to PDQ. Is that how it looks like today?
Yeah, well, and really, I mean, I'm not a strong authority on this, but I think that some of these QHINs will only expose fire to their participants. So Health Gorilla, I think, is one of those that is doing a service. It's converting everything that's QHIN into fire, and therefore it doesn't offer to its participants XCPD, and that's fine. That's that's a choice. That's the beauty of these QHINs, is they can try that out, and I applaud them. But yeah, and I've certainly talked here. I think there should be I think the EMS community should itself rally together and be a QHIN. Therefore, all the participants within the EMS community can use some fire-based APIs and never worry about the QHIN protocols, even as they change. But that takes effort, right? So, but yeah, I absolutely. That's the beauty of these things, can easily translate.
Yeah, so as EMS vendors consider, what networks they might connect to, then these are the questions they can ask probably, and that would inform what kind of development they're going to have to do. They might know that, oh yeah, this particular network, we can sign up with them. They provide PDQM, so we will just develop to PDQM to talk to that network. We'll let the network worry about all the network to network stuff. Or another network might say, yeah, we don't do PDQM, but you can do XPCD and run with that. And a vendor could consider if they want to do the development work to do that.
Well, and recognize that, like I said, there are solutions out there. A lot of the infrastructural solutions that we see in healthcare as typical intermediaries, interface engines, they already support XCPD. So an interface engine can give you an easier API that you interact with, and they'll do the XCPD hard stuff. So, there's plenty of solutions available that just kind of hide the XCPD complexity from you. And quite literally, although this looks highly scary, once you've coded it, it easily boils down to something this simple. And once you've coded that, it's just simply, okay, what data do you have? Put it in. So.
Great. I want to open it up to other questions from participants. Anything that John's covered that you're wanting to dig into a little more or have questions about? And if so, you can unmute yourself and bring up the question.
Let's see this one. There's some questions in chat.
Yeah, I think I just put in some of the abbreviations.
Good. Yeah, I do talk acronym soup, so I appreciate that, Jeff.
No problem. From those vendors on the call, I don't know if anyone would like to just share with us which of these profiles you have implemented or have worked on implementing. Kind of what have you seen in your experience as you've been trying to connect to networks? I do see David from the Utah Clinical Health Information Exchange or Utah Health Information Network. David, I was wondering if you're in a spot where you can unmute, looking from the perspective of the Utah network, if EMS software was to start communicating with your network, what profiles would you be expecting them to use for patient lookups?
That's a really good question, Josh. I think we have some heterogeneity or some different, because of all the different agencies that we could potentially receive information from, we would want to have a toolkit that would have as many of those as possible. We definitely want to look at following the current trend that is being projected out nationally right now. I don't have all that information. We're just starting to wire up, get into conversations about wiring up more data feeds from different agencies across the state. And so I'm actually new to which potential ones will, or which ones will need to be using for, like, you know, agency X or agency Y. We definitely feel like we want to align with what's going on here so that we can participate in the or be effective in sharing and exchanging information. And we have a clinical health information exchange. Utah's unique because we have a claims clearinghouse for all of the healthcare providers, payers, et cetera, in the state. And then we also have a CHI, which is the clinical health information, where we're collecting, like, for example, right now, we've already been collecting false data with the ePulse, so forth. So we're looking to expand that out. And we definitely want to align with the trajectory that is being presented here. So I don't know that there's a single one, but there's definitely got to be a prioritized list, maybe a top one. And as we were waiting for the spring, I think in the next couple of months, we're going to be talking to one of the principal agencies in the state. It's the largest one. We have that on the radar. And so as we get more information about that, we want to make it we see our role as trying to make it as easy as possible for the agency and all of the other stakeholders that we'll put in the heavy lifting that's necessary. So if we need to carry more than one type of profile, more than one type of routine, then we want to do that. We want to build that, and we don't want to lose data because one agency out in the corner of Utah, or down in St. George or something like that, or another vendor is on a different system, if that makes sense.
Yeah, and the nice thing, of course, about coalescing around these existing profiles is that it reduces the number of different implementations that anyone has to do on both sides and gets it down to maybe just a couple choices, which is nice. Thanks for letting me put you on the spot. Anyone else with comments on what you're seeing today as you try to make connections to do patient demographics, patient lookups?
Josh, this is Catherine. Can I ask a question? And I'm sorry that I was late to the meeting, but I was on a call about mobile driver's licenses, and it was fascinating. And Utah has mobile driver's licenses. So are any of you using that mobile driver's license to automatically capture that information and populate your EHRs?
Yeah, so this would be data that's held on the person's smartphone. Is that right? That we could somehow transfer to the EMS provider?
Mm-hmm. I'm just wondering, if anyone is doing any of that, because I'm interested in sharing if you are in Texas, of course, but I'm also interested in hearing how it's going.
Catherine, I can't speak for all of the states. I can say from like a health standards perspective that there has been work done both in the ISO committee for MDLs as well as Kantara, and I think maybe in California, where they've tried to align MDLs as an ID proofing and characteristics to then associate with a patient's record. But I don't yet know how sophisticated that is, or I think, for instance, I think Apple is doing it a bit with theirs. That's obviously a proprietary solution. But that being said, I do think there's lots of grounds to be had to do that as it becomes more popular.
Oh, the only reason I brought it up, Jim, is that David was from Utah. And I know that Iowa, Utah, and California has a pilot about 1.5 million. So I thought, oh, right, this is serendipitous that I'm meeting somebody from Utah immediately afterwards. And David doesn't want to be my friend, I guess.
No, yeah, sorry, I was on mute there. Yeah, I appreciate that. We see that there's a national trajectory coming together really well since all of this has started. And we are anxious to be a part of that and facilitate the burden that the agencies have in collecting and distributing their data to their stakeholders. And we also want to facilitate distributing information back from EHRs from the hospitals so that they can improve their quality. And we feel like we're committed to following the trajectory, no matter how many pieces we have to build to that. So right now we don't have it narrowed down, but the next few months will provide us more information on. We'll be learning more about that really soon.
Though separate but very related, the Governor Hogg signed a bill last year to do a citizens digital identity pilot in Utah specifically. I think you're the first state in the union to actually do that, and it is supposed. I think it ultimately ties in citizen ID and MDL. I don't know if healthcare is one of the sectors they're looking at, but as a state, you're actually farther ahead on the digital identity front than others.
Yeah, I've heard some good things about that as well. So we appreciate that feedback. We want to continue to build on that. And so that's why we're here sitting in.
Yeah, great. Anyone else with questions, especially for John as he went through these profiles, or with just experiences you've had trying to implement these profiles or trying to do patient lookups in networks? Last call. Okay. Well, John, thank you very much. I think that presentation you gave today was perfect. It brought a lot of clarity to where EMS should focus when they're doing patient lookups, and where the EMS vendors can focus their efforts around the right profiles. So thank you again for the great information and clarity that you brought. We're going to go next to Catherine Lusk, and Catherine's going to take a few minutes to talk to us about a a policy, I guess you could say, or guideline from the American Health Information Management Association about patient naming. So really kind of saying, hey, you know, we've got all these systems out there, we've got all these patients, and they go by a bunch of different names sometimes. I'm Josh, but I'm also Joshua, and sometimes I have a middle name, and sometimes my last name gets spelled wrong, and all of that. And so they've come out with a policy to help healthcare providers kind of I guess you could say standardize how they handle patient names, especially in the ambiguous cases. And so I thought it'd be helpful for Catherine to just give us a little bit of an orientation about what this policy addresses. It's a little bit outside of like the nuts and bolts technical stuff that we just reviewed with John, where we're looking at, you know, what's the actual data going across the wire and looking at XML and JSON and all of that. But I think just as you're developing your systems, I think it's helpful to have this policy and this information in mind as a resource that you might, you know, it might be more of a training resource for EMS providers, and more so than maybe something you would implement at the technical level, but I think will be helpful nonetheless. So I want to turn it over to Catherine to kind of fill us in on that policy.
And thank you, Josh, for that great introduction. And the thing that is the most important is technology is great, but technology is only as good as the data that goes in, right? So if you have data that's not very good, you can't technically do very much about it. And healthcare is actually a human sport. It's a team sport where we're changing out information. Patients go from EMS to hospital to doctor's offices to home health. And those people, those little tiny people in the middle are the people that are waiting on us to get it right. And it's hard. And collecting that information in the different settings in a trusted manner, and that it's reliable, is just really, really hard, isn't it? Particularly for the EMS providers, because you're kind of looking at people as they go along, and you're trying to, in a situation a lot of times where things are going really quickly, trying to figure out how can we capture that information and what difference does it actually make. So I'm giving you an example right here of how different people can be collected. And technology can only take you so far. This little boy was born in a hospital, baby boy Smith, and that's his address. Then he gets transferred by the EMS service, and he gets a name. But his address is a little bit different because they put zeros or they put O's instead of zeros. And then he gets to the NICU at the hospital, and he gets his full name by his parents, and the address looks a little bit different. It's Westerland instead of West Esterland. And they capture a cell phone and an email address. So as you go through each and every one of these settings, you can see how that entering that data in an inconsistent manner is making a difference. So that record is not traveling with the individual. Clinically, that information is siloed. The birth hospital information is siloed from the NICU hospital, from the PCP office, to the public health office giving the vaccination, all because we captured the name in a different way. Not that anyone's right or wrong, but there are mistakes, manual mistakes, and there's different elements entered. So there's a practical solution that's vendor agnostic. It doesn't matter what technology is to adopt the AHIMA patient naming policy. Actually, it's naming policy now. It's broader expansion, because with direct secure messaging, we find out that entering the provider's name in the directory in an accurate manner is also important. And it also supports Project USA, which is capturing address. So here is the AHIMA patient naming policy. It standardizes the way you capture names. It encourages the use of trusted documents like driver's license, visas, passports, to capture the information, whatever is the complete legal name. And you always enter the complete legal name. You can enter the nicknames, alias, preferred names in another field. So clinicians know to call them by that, but not to match their medical records. One of the things that I always tell the people is, my brother's name is Bo Miller, but that's not his real name. It's Carlton Ray Miller. Well, my brother has heart conditions. So when he goes to when he goes out of town, I always make sure that he tells everyone, my name is Carlton Ray Miller, and show them his driver's license so his cardiology records can travel with him. It would be a shame for him to present to an emergency room and then to look at him, and he looks very, very fit, for them to not recognize that he had a cardiac condition. I'm not ready to lose my brother. So all of you, that's the message that I'm kind of carrying forward to you, is use the legal name. And the legal name is on the driver's license. Now I realize that a lot of times EMS people don't have the driver's license, but this is also an adage of mine. Seven times nothing is nothing. So if 3 of those times you have the driver's license, use the driver's license to capture it, and you're helping 3 out of the 10 times. But we also, with AHIMA, talk about what to enter in for information. George 7 Jones. 7 is sometimes somebody's middle name, their 7th child, and how to enter that information accurately. This is a first name field, what to enter. Period should never be entered. Middle name field, always enter the middle name if you have it. Joshua talked about sometimes he's Josh, sometimes he's Joshua, and sometimes he's with a middle name. Well, what the wrinkle is you wouldn't think that there are very many Catherine Lusks in the world. Well, there are about 12. So if I don't enter Catherine Gail Lusk as my legal name, that doesn't allow them to properly identify me. So each and every one of those elements that are part of your legal name make a difference. And those profiles that John was talking about that allow matching patients will allow an easier match if you enter the complete legal name. Here's the last name or surname. Capture as recorded on the government-issued identification, including spaces and hyphens. Address is important. Locating and why is it important? Well, you guys know more than anybody else why it's important, because you have to be able to find the person. But another reason that it's important is once that individual gets services like from durable medical equipment, home health services, they have to be able to find that person. Also, for monitoring public health, COVID taught us that, is that being able to locate where an individual is so that we can track disease. Mailing of medications are now coming in the mail, or they have been for some time. Patient matching, which is what you guys are concerned about. Meals on Wheels, getting to people with food insecurities. So getting that address correct and using Project USA's format is really, really important. So here's an issue. It's kind of like the toilet. You just flush it right down the toilet. You don't capture the address right. And how many of you struggle with that in your own organizations? So here's Project USA. And AHIMA worked with the Office of the National Coordinator on a companion guide, just like our patient naming policy, that directs people on how to capture addresses and patient names correctly and gives examples like, what do you do in Puerto Rico? What do you do in New York City for blocks and things like that? So all of those things are important. And this is just an easy peasy little presentation to kind of show you the difference. I can always provide more, but I just really wanted to show you what the difference is and the information that's included on that companion guide that you can use. Additional information makes a difference. Mo Simpson from Children's Health System of Texas in Dallas, when I was working there, worked with the Social Security Administration to increase matching for pediatric patients, because the Social Security Administration, understandably so, uses Social Security numbers. Well, pediatric patients don't necessarily have an SS number, but by adding the phone number and an email address, they increased the matching to 94%. So that was a 20% match on children for disability determination. And that is huge. So those families were able to receive their benefits much faster with the Social Security Social Security Department adding those different elements. So the reason I tell you all that is because that information is also helpful for you with your patient matching. So resolving the problem that we showed up here and here, this little man, this little technology can only take you so far, but accurate data makes a difference. And getting accurate data in there, you can do it technically by scanning the driver's license and having it auto-populate, which I was talking about with mobile driver's license earlier, or you can manually enter the information. But dirty data in is dirty data out. So you can make a difference by adopting the AHIMA naming policy, and it's easy to follow. And you can adopt Project USA address capture. You can educate and communicate the value, and you can capture additional data elements like the telephone number, and you can work with your vendor partners. And there we go, and those are my references. Now, do you have any questions? And I went through this really quickly because I was late and I didn't want to make you guys wait too long. And Joshua's already put a link in there about the AHIMA naming policy. I will then send the slides to everyone. Do you have any questions?
Any questions for Catherine?
Now, David, what kind of policy are you using for your EMS service in Utah to capture names?
You know, right now on the ePulse data feed that we have coming in, I'm not familiar with that exactly, you know, what framework we're using, but we definitely want to gravitate and validate that we are approaching this standard because all of these things make sense. And I was thinking when you're asking questions, what could I say that's helpful or think? One thing is, do any of the stakeholders show resistance on any of these points, or is there?
No, I think, David, it's incumbent upon us as healthcare workers to help people to understand that it's important to us to have the complete medical record available, that we all want for patients to be treated as completely and accurately as we possibly can. And in order for that to happen, to pull together the complete medical record, we need to capture the complete legal name to do so. Otherwise, people are acting in silo.
Yeah, yes. So definitely, I'm writing down as we're speaking here, just for transparency, is a list of the things you were talking about typing, even though we have the presentation. But I'm definitely gonna. One of the first things we're gonna do is have a little meeting and make sure we're, you know, in sync with the project US and each one of these as much as possible, because that's an affirmative agreement, and we're in affirmative agreement. The more information in the medical record, the better. But you're right, dirty data in equals dirty data out. So it's best to follow a standard. In Utah, we have the streets, you know, 100 north by 300 west. Some people write out the W-E-S-T. The post office wants it one way. Another company wants it a different way. So having a standard like this is clearly gonna be beneficial across, you know.
I think so too. And Joshua, I don't have all of their email addresses. Can you just send them the presentation I sent you before?
Yeah, we'll post your presentation in the GitHub repository for all these task force calls, and people can grab it. You know, and oh, go ahead.
And I am more than happy to present to at any point in time if you guys want me to, or I'm happy to get somebody from AHIMA to present.
Great, thanks. And for the EMS software vendors, as you know, the NEMSIS data standard, you know, if you go look at the data element, for example, for the patient's last name, right? And all it says for the definition is it's the patient's last or family name, period. And there's no further guidance in the NEMSIS standard itself. And so resources, this can be an additional resource to provide guidance, like, okay, we've got the technical spec that their last name is going to be, you know, between 1 and 60 characters long, but that's all the technical spec says in NEMSIS. And so here's some additional resources that could be useful to your customers.
Mm-hmm.
Well, Catherine, thanks so much for giving us an overview of the naming policy and the Project USA address spec as well. So let me get my screen sharing back on here. There we go. Okay, so the questions we hoped to answer today were, what are the standards and profiles to use for the patient discovery phase of the workflow? And what role does EMS software play in those profiles? And then to know about the resources to improve patient matching. So we've got the QR code for the survey for this call, feedback survey that's on the corner of the slide. And Lisa is going to throw that in the chat as well. So I would invite you to go ahead and fill out today's survey. It just takes like a minute or two to let us know if we need to spend more time on this topic or if we covered it sufficiently, and any other feedback that you'll have. In terms of next steps, do the survey. You can, I think all of you here are on the email group. I will be updating the GitHub repository with Catherine's presentation. I'll check with John to see if I can get his in there as well. And I'll also be updating content in the wiki, just documenting what we learned today. And then in terms of next topics for the task force, I wanted to ask you all. So one topic we could cover is the APIs. And when I talk about APIs, kind of looking at like, we've already talked about what types of documents might be shared. For example, in the outcome phase of the call, EMS might request a discharge summary from a hospital. So a discharge summary is a specific kind of document. When I say APIs, I'm talking about, well, how do we actually make that request, and how does that document get delivered? And so that's stuff like the IHE profiles for cross-enterprise document sharing or mobile access to health documents. So I'm curious from all of you, if you feel like you've got a good handle on those APIs, or if that would be a great next topic for us to understand cross-enterprise document sharing, mobile access to health documents, and others. Then the other topics that we're going to get into are going to be actually a little more clinical perspective, but tying the clinical to the technical. So we'll say, what are the pieces of information that the providers need? And so we know what documents we have, therefore we know what data is available in the documents, but what do the providers need? And where does it match up with what's available in the documents? Is there data they need that's not already covered by the specs? And then I'm sure there's tons of data covered by the specs that the providers don't actually need. So we don't need to worry about that data, really focus down on what's pertinent to them. So I wanted to ask that question of all of you right now, just to get your thoughts on where we stand so far. Do you want to cover the APIs next? Or do you feel like we've covered them enough in the past and you want to jump into just identifying the clinical data needs?
Joshua, we had a meeting this morning in Texas, and the PCPs were communicating that the information is too much.
Mhm.
And so I'm wondering, and it's because it's not defined enough. So we're going to start defining it on, or at least recommendations on what's the best practice. So it would be wonderful if the EMS community would then, if you guys could start to do that, and then I'd love to communicate that back to my providers in the state of Texas and the PCPs and the hospitals so that they could make sure that they send the right information to you guys, that when you query, you get what you need. So that minimum clinical content would be wonderful. You can always query for more, but that would be a beautiful thing.
Yeah, exactly. I've heard of cases where a system receives a consolidated clinical document architecture document, runs it through a style sheet and converts it to HTML and shows the entire thing to the clinical provider, rather than picking out the pieces that the provider needs. And for EMS, that's even more important because of the time-sensitive nature of their encounter with the patient, that rather than wading through an entire CDA that's been converted to HTML, they probably just want to see certain things that are important to that urgent care to the patient. So that's the kind of stuff we'll be looking at. Yeah.
That would be beautiful. And once you come up with that, I'd be glad to share that in Texas. And I know that our clinicians would appreciate it because they want to be good partners.
Yeah. Great. Others with thoughts on where we go next?
This is David again from Utah. It would be helpful again for us at some point to have a refresher on the APIs and so forth. That I am going to be sharing some of that information with other people. And although I've sat in on some of them before, because we'll be bringing other, resources into the equation, having that greater understanding, more solidified about that is connectors, etc., would be very useful. I think it might not be the first priority. I like what Catherine said about that's just as important, so.
Great, thank you. Okay, well, hearing no others, I would invite you again to use the feedback survey to give us some further direction on where we go with the February call. And then we will plan on reconvening second Thursday of February for the next call. Just as a heads up, the second Thursday of March is during the HIMS 24 annual conference. And so I'm anticipating that we will cancel the call in March, since I know at least I myself will be at the HIMSS conference, and would look forward to seeing any of you who will also be there and taking some time to sit down and chat one-on-one. So thanks everyone for the participation in today's call, and I hope you have a great rest of the day.